Hi, everyone. My name is Michael Stewart. I am with the OI Foundation, and I want to welcome everyone to today's Rare Bone Disease Teleecho Clinic. Today we have Dr. Sandhaus presenting for us. But before we jump into that, we're going to be going over a few announcements for everyone. As a reminder, today's session is being recorded. We're going to put this recording on Zoom, or rather on YouTube, for everyone to review afterwards. Before we jump into that, please, as always, we're going to post a link into the Zoom chat to sign in for today's session. Please do this. This helps us with our reporting information that's required for us. This really helps us out. Even if you don't put it in your own name, I have to go back afterwards and put in your name for you if you don't. So please help save me some time later, and please sign in yourself when you see that link. Also, at the end of today's session, we're going to have a red cap link for evaluating today's session, and that's also how you get your free CME as well. That'll be posted near the end of today's session. And then I'm going to actually introduce Dr. Laura Tosi, who's our medical director, and she is going to do the rest of today's announcements. Dr. Tosi, hello.
Hey, welcome everybody. And again, welcome to year 7. Can't believe we're doing this, but it's been great. Before we start today, just want to let you know about a couple of wonderful upcoming opportunities. Next month, Christopher Kovacs will be talking about maternal mineral and bone metabolism during pregnancy, lactation, and post-weaning. And then in November, Uti Makiti will be talking about heritable non-OI forms of osteoporosis. So very different, but hopefully very engaging topics. Then the last or next to last session of the OI teleechos will be on October 8th. And my colleague from Children's, who's a terrific geneticist, we'll be talking about clinical and genetic evaluation of non-accidental trauma versus OI, a topic that continues to come up for many of us. Next slide. Then, as you know, we're trying to work hard to engage the greater community that might eventually help take care of our patients as they move from pediatric to adult care. And so we have reinitiated a metabolic and rare bone disease club here in Washington. And, you know, Zoom has taught us so many things. So we will have an in-person dinner for anybody who's in town tonight, 6:30 at the Pooks Hill Marriott. If you are on this call and say, oh, maybe I should have signed up, please come. And please recognize that we're also presenting this on Zoom. And the talk will start at 7:15 or 7:30. Help me, Melissa.
7:30.
7:30 Eastern Standard Time. It's too late to technically sign up, but if you are wanting to be on Zoom tonight or come to dinner, please reach out to Melissa Bernardi, M. Bernardi, at oif.org. As part of this call. We welcome you. And then on November 13th, that club will be looking at achondroplasia. Next slide. Hope you'll start joining that as well. Then one of the great things that the OI Foundation initiated now, I believe over 20 years ago, are the Michael Geisman Fellowships. It's a $50,000 one-year grant, but with a second-year extension available. Applicants must hold an MD, DDS, DO, or PhD and be within 5 years of completing their training. But we have had all kinds of variety in the awardees. So basic, clinical, and even social science research is welcome. So those applications are due by when? Michael.
Oh, I was just reading this.
We'll work on that.
I can look it up and put it in the chat.
When we come to halftime, we'll have that announcement. Sorry about that. All righty. And next slide. So now, with no further ado, it is a great pleasure to welcome back Dr. Sandhaus. Let me point out that we do have a couple of cases at the end, so be sure to stick with us for the cases as well. So, Dr. Sandhaus, a great pleasure to have you here to talk to us with all the new updates on pulmonary care in OI. Welcome,
Great.
welcome.
Thank you very much. It looks like I'm not seeing my slides.
We are not either. So
Are
I
you
just made
sharing
you
your screen?
Do you want me to share my screen?
co-host. Is the
Do you
share
want me to
button
share my
there?
screen?
Yes.
Yes, please.
Because it looked like the slides were there before the screen disappeared. I'm afraid if I have to share my screen, I have to go grab the presentation from my other computer.
Michael,
So I will do that.
those slides, we can have them up for you.
Yeah.
Sorry. Miscommunication.
Yeah.
We can fix that right away.
I get a chance to look and see who's here. Well, I'll start by saying thank you all for great. Thank you all for attending, and I look forward to telling you about some of the continuing research we've been doing in pulmonary disease. And can you make that now full screen?
One moment.
Good recovery. Thank you. I can't believe it's trying to generate an animation. That's terrific. Great. Anyway, the lungs in OI. Don't keep going. Go back. Go to the next slide, please.
Sorry.
Okay. The lungs in OI. The lungs play a vital role in the body. Thought you'd like to be reminded of that. Osteogenesis imperfecta can impact various aspects of lung function. Scoliosis is prevalent across all forms of OI, and scoliosis, as I'll present to you, can certainly affect lung function. The defects in type 1 collagen that compromise bone integrity in OI also affect the type 1 collagen present in the lungs. And type 1 collagen is a key connective tissue component of the airways and alveoli. Next slide. So, why be concerned about the lungs and OI in general terms? Well, clinically, pulmonary issues have a major effect on quality of life and health status in OI. Majority of OI patients die from or with pulmonary disease. Pulmonary problems in OI are not simply related to changes in chest wall architecture. And even when pulmonary problems are not caused by OI, they can be more severe in the OI patient than in someone without skeletal abnormalities and other type 1 problems, type 1 collagen problems. Next slide. So today I'm going to discuss the role of mechanisms in addition to scoliosis in pulmonary abnormalities of OI, the difficulties involved in applying usual physiologic and radiologic testing methods to evaluate the lungs of OI patients, and the results of studies attempting to identify and quantify the burden of lung disease in adults with OI. Next slide. So here is my little accordion of lungs. These are lungs, represent lungs in full exhalation and full inhalation. And then one more click. And my representation of the lungs with scoliotic chest architecture. You'll notice they don't have any dental problems in that illustration. One more click. So the effect of scoliosis on lungs, the lung is compressed on one side and expanded on the opposite side. Could you click again, Michael? Good. It's compressed on one side and expanded on the opposite side. The overall chest movement during breathing is often highly compromised by the rigidity of the rib-spine interaction. Airway clearance mechanisms can be impaired, and just by scoliosis itself, but they're even more impaired when we talk about other mechanisms that OI affects the lungs. Overall lung capacity is generally reduced in patients with scoliosis. And these facts are all true whether we're talking about scoliosis in OI individuals or non-OI scoliosis. Next slide. So I'm going to give you a little glimpse ahead of where we're headed in this presentation. Next slide. I'm going to be discussing two of the more prominent findings that we've published and that we've noticed and confirmed now that we've enrolled more patients in our cardiopulmonary study. One is the appearance of unexpected bronchial wall thickening. Next slide. And the second is bronchiectasis, which is, as you know, loss of the normal tapering of the bronchial true, loss of wall integrity, and all of this leads to poor airway clearance mechanisms and risk of chronic infection in the airways. Next slide. So by way of background, we are obviously not the first group to ever look at lung disease, and lung disease in OI has been studied in many countries by many investigators. Publications have included documentation that cardiopulmonary complications are a major cause of morbidity and mortality in OI, that pulmonary impairment commonly leading to restrictive physiology in patients with OI may cause shortness of breath, fatigue, increased susceptibility to lower respiratory infections, and sleep problems. However, the etiology of cardiac and pulmonary manifestations of OI remain unclear, and guidelines for clinical management of pulmonary disease in OI are vague or non-existent. Next slide. Pulmonary insufficiency in OI has been ascribed primarily to abnormal chest wall architecture leading to stiffness. There are publications documenting pulmonary insufficiency is often thought to be the result of chest wall abnormalities. In the general public, we know that scoliosis curves greater than 60% are correlated with pulmonary compromise. Since scoliosis is a common OI complication, the initial suggestions were that pulmonary compromise was most likely due to its presence in this population of patients. However, evidence of restrictive physiology in individuals with OI who have mild curves or have no scoliosis were published that indicate the possibility of an intrinsic pulmonary defect. And since type 1 collagen is a major structural and connective tissue in the lung interstitium, it's certainly possible that that intrinsic lung disease may be due to this underlying collagenopathy in both the lung parenchyma and airways. Next. I'll mention some cardiac risks during the course of this presentation because this is a cardiopulmonary study that I'll be focusing on. The literature suggests an increased risk of cardiovascular disease compared to the general population. Mild tricuspid regurgitation, aortic root dilation, increased ventricular mass are also commonly reported complications. Type 1 collagen is an important constituent of heart valves, chordae tendineae, interventricular septum, and aorta. And reduced pulmonary function can also exacerbate cardiac problems. Next slide. So our study is a cross-sectional study of currently 60 patients enrolled. And we are anticipating moving this into a longitudinal study if we're able to. It's observational. It enrolls adults and teens, as you'll see for the inclusion criteria and exclusion criteria. This work has been able to be accomplished thanks to grants from the Osteogenesis Imperfecta Foundation, the Brittle Bone Disease Consortium, and the people who support those organizations. Next slide. So our primary hypothesis is that reduced pulmonary function is intrinsic to osteogenesis imperfecta and is not exclusively related to scoliosis and/or abnormal chest wall architecture. I think I've gotten that message across. Next slide. Our inclusion-exclusion criteria are that we have to have a clinical or genetic diagnosis of OI, and we accept all volunteers with respect to type of OI. We initially enrolled only adults, but we recently amended the protocol to enroll patients who are 15 years of age and older. We do exclude people who have had an acute respiratory illness within 6 weeks of enrollment or who are undergoing diagnostic studies for an active disease. And people that have pre-existing diagnosis of cardiopulmonary comorbidities that might affect lung compliance, such as fibrosis, are excluded from the study. Next slide. In terms of data collection, all the patients that I'll describe have been offered the opportunity to have spine x-rays, a high-resolution CT scan of the chest, complete pulmonary function tests, 6-minute walk test or a 6-minute hand bike test for those who are not ambulatory, sleep study, which patients can choose not to participate in, as they can choose not to participate in any study procedure, echocardiogram, EKG, and oximetry. Next slide. We also do 4 surveys. The short form 36, general health quality of life survey, the St. George Respiratory Questionnaire quality of life survey that focuses and has been validated in patients with respiratory disease, and 2 sleep questionnaires, the Pittsburgh Sleep Quality Index and Functional Outcomes of Sleep Questionnaire. Next slide. That's St. George, by the way, under the dragon. Challenges in evaluating the lungs in OI. This is something that, if you've heard me speak before, I tend to concentrate on a lot. I guess I want to show people how difficult my job is. But the problem there are a couple of problems. First of all, with pulmonary function testing, the question that always arises is, how do you identify whether a given individual's value is normal or abnormal? That's usually done in standard pulmonary function testing by calculating the predicted normal, which in current status is calculated based on the individual's height and age. Sex and race used to play a role in predicted normal values, but as the population has become more homogeneous and as people's diets have standardized and things like that, it's become apparent that race and sex don't play as large a role in these predicted values. So that means that one of the criteria used to calculate normal values can be very difficult to measure in a patient with OI. Not just the measurement of it, but the implication that the measurement of it reflects the size of the chest wall and the expected capacity of the lungs. In individuals of short stature, obviously these calculations can fall apart, and surrogates for height have been used, such as arm span, but in those with long bone fractures and deformities, these surrogates can be imperfect. Just to kind of remind people, when we do pulmonary physiology studies, we generally classify patients to be in one of 3 physiologic buckets. One, they're normal, or the others are that they have obstructive physiology or restrictive physiology. And obstructive physiology is characterized by certain tests done during pulmonary function testing the forced expiratory volume in 1 second, which is the amount of air that can be inhaled with a forced expiration in 1 second, um, um, is low in an obstructive physiology, especially compared with the forced vital capacity, the amount you blow out from top to bottom. And this leads to a ratio of those two values, FEV1 to FVC ratio, that's less than or equal to 70%. And that FEV1 FVC ratio is kind of the gold standard for defining whether the physiology being observed is obstructive. Generally, the total lung capacity, how much air is contained within the lung at the top of a breath, remains normal or increased. There's also an increase in residual volume, how much air is left trapped in your lungs after you've breathed out as much as you can. So this reduction in airflow leads to shortness of breath. Air gets trapped in the lungs after full expiration. And examples of classic obstructive pulmonary diseases are chronic obstructive pulmonary disease, asthma, chronic bronchitis, asthma. The restrictive physiology has a reduction, an often symmetrical reduction in FEV1 and FVC. It is characterized by increased a decrease in the compliance of the lung, an increase in the resistance to movement of the lungs, and that leads to an FEV1 over FVC ratio that's greater than 80%. And the two criteria that are generally used for making a diagnosis physiologically of restrictive physiology are elevated FEV1 FVC ratio and a reduced forced expiratory volume in 1 second, and FVC. The reduction in lung volume is difficulty inhaling air in the lungs due to the stiffness inside the lung tissue or the chest wall cavity. And examples of these are pulmonary fibrosis, other interstitial lung diseases, scoliosis, and perhaps osteogenesis imperfecta. Next slide. We've attempted we and others have attempted to solve the PFT measurement dilemma. Milder OI with little scoliosis or none can often use the usual calculations for predicted normal values. So type 1 collagen, many type 1 collagen, type 1 OI patients are acceptable for using those predicted normals that are calculated based on the height and the age. More severe OI, especially individuals with short stature, can have arm span has been used as a surrogate for height, but there are problems if there have been multiple extremity fractures, rotting, elbow contractures, bowing, etc. We have evaluated other measures of trunk height as surrogates for height, but they've proven imperfect. We have tried to modify the use of fingertip to fingertip arm span measurements, which is how it's usually done, by doing point to point arm span measurements, as illustrated in the diagram, where you measure each segment of the arm, shoulder, back, and the other arm, and add those together. And I'll show you in the case presentation that I have the differences between those measurements and in some of the data that we've collected that I'll be showing you as well. Restrictive physiology issues. Restrictive physiology can be caused by increased stiffness of the chest wall or by intrinsic lung disease, such as pulmonary fibrosis. Distinguishing between these mechanisms involves more invasive testing that's kind of fallen into disuse. Lung compliance measurements by having patients swallow a partially inflated esophageal balloon allow you to measure the pleural pressure during inhalation and exhalation, and that can differentiate between chest wall restriction and intrapulmonary restrictive disease. Therefore, we'd like to be able to find surrogate measures that could be used. And our current solution is that we're using the FEV1 FVC ratio alone without FEV1 FVC values to evaluate for obstructive versus restrictive physiology, because the FEV1 FVC ratio of those absolute values does not require the kind of normalization that needs calculations based on height. Next slide. So I'm going to now turn to the pilot study that has been going on since before COVID, enrolling patients to look at their cardiopulmonary status. We currently have 60 active participants since we started enrolling in July 2017. We're actively enrolling more subjects and including participants at the 4 sites I'll talk to you about. The results from our initial cohort of 30 adults with OI are summarized in a manuscript published in Clinical Orthopedics and Related Research. And there's a kind of a reference to that. But I want to emphasize that the results from the current cohort have been submitted for publication, but have not been published yet. And therefore, whenever I show you data that's from the 60 active participants, I'm going to remind you that this is unpublished data. Next slide. Here is our first slide with unpublished data. As you can see, we had 21 males and 39 females. That is our 60 patient cohort at present. The data we presented when we had 30 patients enrolled was much more dramatically dominated by females. And we added 2 additional sites with a charge to try to enroll as many male patients as possible. And that's how we've been able to begin to try to equalize the enrollment of male and females. You can see that there's a variety of OI types with single representatives that were type 8 as well as Bruch's syndrome 2. And the majority were not the majority, but the largest cohort was type 1, as well as type 3 and type 4. About 62 of our percent of our patients had, I believe that should be in the other column. Oh, there it is. 62% of the 32% of the patients. Let me take a breath. 53% of our patients have had genetic testing to document their OI type. I'm highlighting the height values in this table because if you look at the mean height measured directly, it was 143 centimeters. If you look at the arm span height, it's 149 centimeters, 146 centimeters versus 140. So you do get closer to a person's predicted height, presumably, by using arm span. And point-to-point arm span added a significant amount to that height measurement. And we think that's more reflective of what the patient's chest dimensions would be in an individual of that height, but still not perfect. You see that we have 91% never smokers and other aspects of the demographics and characterization of our 60 patient population, and the mean age was 42 years. Next slide. Here's Dr. Raggio's favorite slide. A little complicated, but let me walk you through it. Remember the FEV1 FVC ratio with a midpoint essentially at 0.8 or 80% FEV1 to FVC ratio. And those to the right of that are thought to be restricted, and those to the left are thought to be obstructed. Although, once again, the cutoff for calling something obstructive lung disease is an FVC, FEV1 FVC ratio of 0.7. And we only have 2 patients in this group that are classically obstructed. This array of colorful triangles and dots and squares has a key up at the upper right. You see that we've broken them down by type of OI, and we've also drawn some trend lines for the type 3 patients and the type 4 patients, showing that as someone gets more restricted, we're not necessarily seeing a higher percentage of degree of scoliosis as indicated on the ordinate. So, and we have a fairly large number of individual restricted patients at the bottom right that have perfectly normal anatomy of the spine, or at least near normal anatomy of the spine. And this belies to a certain extent the primary place for scoliosis as the etiology of restrictive physiology in OI patients. Next slide. This is another slide from the full cohort, and is therefore unpublished data. And this shows you broken down by sex, male on the left, female on the right in orange, of the primary findings when we looked at CT abnormalities. You'll see that the primary abnormality that we identified, and this was an unexpected abnormality at the time that we began the study, was a significant percentage of individuals with some degree of bronchial wall thickening, mild, moderate, or severe bronchial wall thickening. As we've enrolled more male patients, we've started seeing more bronchiectasis, and there is a trend towards a male predominance in the bronchiectasis group. We also see a significant amount of ground glass opacities, which could represent inflammation, infection, or a localized compression of alveolar structures. We see a fair amount of atelectasis in our patients, not surprising because of the chest wall architecture, and also parenchymal scarring, presumably from previous lung infections and times of inflammation. The next slide shows the same patient group, again, unpublished data, broken down by, can we go on to the next slide? Broken down by the type of OI. And you can see that some of these have a predominance in that single patient with Bruch syndrome, or in the single patient that is type 8. But there's generally a trend towards those with more clinically significant OI having a greater percentage of these pulmonary abnormalities. Next slide. So the results, again, the accumulation of all of our data, published and unpublished. Just to summarize the results, 43 of 59 patients, or 73%, presented with some degree of scoliosis. 2/3 of the participants had restrictive physiology on pulmonary functions with no significant correlation between curve magnitude and lung function. 85 to 86% of the chest CTs showed abnormalities of the lung itself, including bronchial wall thickening, ground glass atelectasis, and bronchiectasis. So bronchial wall thickening was common in both sexes and seen across all types of OI. 58% had abnormalities in their EKG, with readings such as tachycardia, abnormal ventricular relaxation, and T-wave abnormalities. And 82% had either trace mitral or tricuspid or pulmonic regurgitation on echocardiogram, just to include the cardiac, some of the cardiac findings that we found. Next slide. This is a slide that I want to skip. This is the old slide on the number of patients with various things. That was not the 60 patients. This is the summary of our quality of life data and includes both unpublished and published data. The SF-36, a measure of general physiological and mental health scores, were below usual scores for the general population. Lower numbers are worse quality of life. 15 individuals had sleep quality scores that were greater than 8, indicating poor sleep quality. However, the average scores for the FSOQ quality of life indicated high functional status. And the SGRQ, a specific pulmonary quality of life tool, showed higher scores representing worse quality of life in this case compared to the general population, with segments of the SGRQ broken down as symptom scores, activity scores, impact scores, and total score, all of which showed worse quality of life measures than the general population. Differences between scores of greater than 4 points are considered to be clinically meaningful. Next slide.
Sandy, can I ask you a
Yes,
question? Go
absolutely.
back. Hi, Matt Warman.
Hi, Matt.
Can you go back a slide, please, Michael?
Thanks.
So if I'm looking at this general population, let's just take total score. So total score is 6 with a range in the general population of 5 to 7. Is that what that means?
That's what that means.
Okay. And then in the study population, the mean is 13, but the standard deviation is larger than the mean.
Yeah, I guess I'm glad you can see that.
Well, I'm seeing 13 plus or minus 13, 73.78. And I see large standard deviations on all of those. So how statistically significant can a difference be when the standard deviations are that large?
I don't think that we have enough patients to say these are significant. These can be the standard deviations can be larger than the number shown there, because these values are from 0 to 100. That the scale is from 0 to 100. So we could have had some really major outliers in terms of being considerably worse than the mean of the population group. But it does seem strange to me, and I will definitely get back to you to, first of all, figure out why my changing of that did made these invisible, because I'd hate you to think that I tried to cover this up. But I will try to get you a better answer than that. I'm not claiming significance. I'm saying that there's this trend. You can see it's only 41 of our subjects that have completed the SGRQ so far, at least had it analyzed yet. So we'll see.
Thanks.
Thanks, Matt. Thanks for having sharper eyes than me.
Oh, actually, while I've interrupted you, let me interrupt you and ask one other question that I've been thinking about. How many of your participants come from the same family and have the same mutation?
My understanding is that none of them are from the same family, although I can't guarantee that they're not distantly related. But good question. And please feel free to interrupt any of the participants here if I've made something unclear or it raises a question that you want more clarification on. Next slide. So there was positive correlations in our quality of life study between the FEV1 FVC ratio and St. George Respiratory Questionnaire, again, with the number of patients that you saw. There were people with type 3 OI had significantly higher or worse total scores than people with type 1 OI. SGRQ did not by the way, these results are from the 60 patient cohort. This is again unpublished data. So there are more patients here than in the study that we were just quoting on the previous slide. The SGRQ did not correlate with any of the chest CT abnormalities, suggesting that the findings of the chest CT and OI do not directly contribute to respiratory-related quality of life. And compared to individuals without pulmonary comorbidities, those with pulmonary comorbidities had higher SGRQ impact scores and total SGRQ scores, not statistically significant and not necessarily scores expected in those that had higher pulmonary comorbidities. Next slide. So in conclusion, respiratory insufficiency may be intrinsic, maybe due to intrinsic lung connective tissue abnormalities in OI, including scoliosis curve, as well as FEV1, FVC, and pulmonary abnormalities. The scoliosis curve and the FEV1 FVC ratio are not significantly correlated, rather than exclusively due to secondary effects of scoliosis and abnormal chest wall architecture. Let me say that again since I messed it up. Respiratory insufficiency may be intrinsic to lung connective tissue abnormalities in OI, rather than exclusively a secondary effect of scoliosis and abnormal chest wall architecture. Chest CT shows bronchial wall thickening, which suggests a relationship with intrinsic collagen abnormality, and positive correlation between the SGRQ and the FEV1 FVC ratio implies the quality of life is affected by reduced pulmonary function. We clearly want to increase the numbers that we demonstrated in these slides. We hope to be able to move forward with an already written bronchoscopy study to actually look at the histology of the bronchial wall thickening. I will show you what this looks like as we move forward in the case that I'm going to present. But let's talk about where we're going. We're going to increase our enrollment. We have a treatment study that's already started enrolling, where we give people with significant bronchial wall thickening and OI inhaled steroids. It's a new pilot study. It's currently enrolling. We give 6 months of inhaled steroid because we want to give the minimal amount that we can of steroid that is likely to show us a difference. What is that going to tell us? We know that in patients with asthma and other inflammatory lung diseases with bronchial wall thickening, that the bronchial wall thickening is due to inflammatory cells and edema in the airways, and steroid and by inhalation or parenchymally can reduce that bronchial wall thickening. And so this will give us a hint as to whether the bronchial wall thickening is due to inflammation or is an actual result of the collagenopathy. And as I mentioned, we're considering a longitudinal arm to this study. Next slide. The third thing is that we've increased enrollment by adding the study that has funding from the BBDC, which allowed us to become multi-institutional with enrollment at Kennedy Krieger and the University of California at Los Angeles. And we're also looking at the possibility of sexual dimorphism because some of the differences in bronchiectasis, for instance, between males and females. Next slide. So I want to thank our lung collaboration group, especially the group at Hospital for Special Surgery led by Dr. Kathleen Raggio and her team, which includes a large number of wonderful people: Erin Carter, Chloe DeRocher, Caitlin Brown, Jonathan Chaco, and my partner in crime at National Jewish, the head of pulmonary radiology, Dr. Deborah Dyer. At NIH, we have Dr. Sergey Lykin and Dina Markovina, Dr. Soro, also there at National Institute of Health, Roy Morello, who's on this call at the University of Arkansas, Dr. Alexandra Carrerio, Jennifer Ziba, and Nancy Pleshko at Temple University. And at through funding at the BBDC, at Kennedy Krieger, we have Dr. Melinda Wu. Dr. Jane has left for greener pastures. And of course, Dr. Deb Krakow at the University of California, Los Angeles, who helped us enroll a lot of our male patients and continue to participate in enrolling additional patients. So next slide. That should be the last. Oh, I have 2 pages of references, which I'm happy to share with everyone. Any questions that people have at the end of this?
What I'm going to do, Sandy, thank you. Incredible how much progress you've made. And it's just so exciting to see it move forward as well as it's doing. I must say, I always feel very foolish. We knew this was a collagen disorder, but we didn't really recognize for so long how much collagen was involved. Great work. And I'm finding more and more of my kiddos have hidden disease. So important. Mm-hmm. It's a great thing about the longitudinal study. What I'm going to do for a minute is we've had a lot of people.
Can I make one comment that you reminded me of about the longitude? Yeah. One of the reasons that we want the longitudinal study is one of the ways of solving the issue of the inability to get good predicted normals is, rather than relying on predicted normals, is to get longitudinal data. And so we are trying to generate enough data that we can eventually have guidelines about following pulmonary disease. And our proposed major kind of categories of following pulmonary disease that we'd like to suggest people consider are: number one, doing annual pulmonary function testing on older children who are capable of performing pulmonary functions, and all adults, so that even though you can't tell whether a particular value is normal or abnormal or how abnormal, you can still know whether things are changing in the right direction or the wrong direction. And then the second thing is, we think that CT scanning of the lung in OI should become a standard of care. And we're hoping, as this data continues to be generated and the numbers grow, that we'd be able to document the importance of that.